pretty much we're done with block 2 for peds. So we're doing good. We're going through, there's 42 objectives for this one. So it's very similar to last time. What I need you guys to really think about for block 2 is how am I synthesizing this together? I am probably not going to ask you, what is the diagnosis, right? I'm going to ask you, I'm going to paint the picture of a diagnosis, what's the first line treatment? Or, they've done the first line treatment, what's the second line treatment? What are you afraid is the outcome of a treatment? What is the complication of this particular diagnosis? So this is a question, this test is a lot more second and third order than the first test. So the first test is very straightforward. What's the percentiles? What do you expect? When do you start solids? Second test, now I need you to take all of that stuff and to be able to synthesize it together. So if you're not comfortable with the material backwards and forwards, spend the next couple of days on that. I will put the PEDS vitals on there again. Please, dear God, know what a fever is. You guys can do that. Same for the things, like for the common organisms for each diagnosis, I'm not trying, I promise you, I am not trying to trick you with like, oh, this one's a Klebsiella or Proteus or like, please know the most common. So common things being common, stick to that. So the heat bugs for the heat stuff, UTI bugs for UTI bugs, things like that. Okay, so what I need you to know then, for the love of God, what a fever is versus what it's not. What's going to have a fever, what's less likely to have a fever. Can you say what fever with a source, without a source of unknown origin, can you differentiate that? What would those workups look like for each of the different types? When I'm giving you a presentation of a child, be able to distinguish from words what's sick, not sick. Right? If the child is lethargic, if the child is febrile, if the child is not moving, if the child is doing some of those, that's sick. If the child is playful, interactive, mostly hydrated, things like that, not sick. To be able to understand those. And then the management for the different age groups. If you're doing neonatal sepsis protocol versus if it's a fever and they're 2 years old versus it's an older kid that has a fever. So at each of those stages, what is the treatment, what's the presentation, what's the differences in those workups. Meningitis, all things meningitis. So you can read that one. And then the very basics of encephalitis. Encephalitis is going to, again, look a lot more like the whole parenchyma as opposed to, or a little bit more focal potentially with meningitis. In ID, I would pair, when you're studying, I would pair ID up with derm. Because a lot of things look like fever and a rash, fever and a rash, fever and a rash. So if you can differentiate when I'm trying to talk about an infectious etiology versus a dermatologic etiology, that's going to help you out a whole lot. So the key features, right? If I say a rash starts here, or the baby came out with this rash, or there was this rash, and or there's a fever and then a rash, or what was the order of events, that's going to matter a whole lot. I think half the vignettes on this test start with fever and a rash. So when I really looked at it, I think about half your test is some age child comes in with fever and a rash. Which ones are itchy or not? That's going to help you distinguish and then know which of those do you do nothing for, which of them do you treat. So that's going to be a big distinguishing factor there. And then your at-risk populations, what I mean by that is things like who's most likely going to get, is this a baby issue, is this a little kid issue, is this a first trimester pregnant woman issue? Who are the high riskers for those things? For heat, again, it's the same stuff. When are you concerned? When are you not concerned? When do you reassure? Your eye tests, so most of them, I usually see it on a test and I'm just going to cover, uncover, or what kind of different ocular tests are you doing. If I give you an ocular exam, what is that going to look like? Do you know what to do with strabismus? When does it become amblyopia? The differences with pseudostrabismus? All the different eye etiologies. So if I give you a description or a picture of a kiddo, do you know what to do with that? Do you know otitis? So there's an otitis, a couple of questions. So can you work with that front and back? Can you recognize it? Can you treat it? Can you treat it down the line? What are the complications of that? So we need to know otitis inside and out. For nose stuff, It's a little bit more general, but things that are different, right? You've already seen allergic rhinitis till you're blue in the face. You've seen epistaxis. You've seen sinusitis. So what are the differences? Why would I bring those particularly up with peds? And then some of your pharyngitis. General things. Again, what's different for a kid? Respiratory. If I give you an exam of a respiratory exam, can you pick those apart? And then basically, can you take those summary slides? If I describe croup, can you pick that apart from epiglottitis? Can you pick that apart from RSV? Can you pick that apart from pneumonia? And then if I give you those and you get the diagnosis, do you know how to treat it? So working forwards and backwards with that. So basically all of those. If I gave you a description, could you pick them apart and then know how to treat each of those and who's most at risk? Why is bronchiolitis different than a URI? So that's something to be aware of and know. It is functionally a URI, but why does it go after babies and what does that look like? And then pneumonia for kids, because we treat it differently at the different age population, so can you pick that apart as well? Derm again, put that up to infectious disease. Where is it? Can you identify pictures? So you just had your derm test. There's not as many pictures, but there are a couple, and they're not the ones from your lectures. So they will look similar, but they are not the same exact pictures. GI, do you remember the difference between GER and GERD? So when do you treat versus when do you not? If first line treatment doesn't work, what's your second line? Things like that. All things constipation and ankle paralysis. I put a couple of questions on there about that, so that one's a free for all. You know that one's on there. Who is at risk for celiac? We talked about this with like trisomy 21. Who's at risk? How are they going to present? It's going to look different than the adult who has some kind of diffuse GI pain. And then what are those differences with different types of dehydration and rehydration for kids? And then what does that chronic diarrhea look like? Most recently, again, I'm not going to test you on all the crazy different proteus, Klebsiella, different types of stones. We already have GU for that. We're not doing that. What with kids? Things like a calf when they're under 2. Things like their antibiotic regimen is different for empirical antibiotics. Things like that. Knowing BCUGs, in general, who are you going to do that for when you get the free pass? You don't need to image. All of the VUR grading. So at what grade are you more likely to have a surgical complication or not? Not a lot. This is a shorter lecture. There's not as many on there. Enuresis. So enuresis pairs nicely with the GI lecture, with constipation. So can you work forward and backwards with that? Those are the big topics. I will post this one a little bit later today if you want to do that. Let's do some practice questions. Okay. Taking care of a 5-year-old boy in the ER. He's had 3 days of fever up to 103. Some cough, runny nose, and diarrhea. He's concerned because he's been more tired and isn't responding to their questions. So sick or not sick? Sick, correct. On exam, patient is febrile to 103.5. Vitals have a respiratory rate of 20 and a heart rate of 110. Very irritable. What does irritability make you think of? Meningitis. Yep. Very irritable, doesn't want anyone to hold him. Legs are covered in small red dots that do not blanch when you touch them. What is your next best step? So what is your diagnosis here? Neisseria meningitis. What are you going to do for this kid? You're going to lumbar puncture him, and then what? How would you treat him? What antibiotics? Bank and stuff? Okay. Does he get to go home? No? Okay. So let's see, we do amoxicillin, PCM follow-up, chest x-ray for his cough, lumbar puncture and IV antibiotics, yep. Reassurance, blood culture, empiric oral antibiotics. So, perfect. Clinic evaluating a 2-year-old male for a new onset rash. Mom reports that the child has had a fever for 3 days, so 3 days for rash. So, fever for 3 days, since resolved, has a mild cough and runny nose. Symptoms have been present for 8 to 9 days, now improving. Daycare sent him home due to a new rash on face. On exam, the child is afebrile, has a rash on his cheeks that spares the area around his mouth. The patient would be at highest risk if he came into contact with which patient before the rash developed? So what does this patient have? Fifth. Yeah, what's the other name for that? Lactates. What's the other name? Parvo. Yep, what's the other one? Erythema infectiosa. So I can give you any one of those. Okay, so if you have parvo or any of those, who are your at-risk populations? Sickle cell. Anyone? Yep. And who else? What trimester of pregnancy? Second. Correct. So does a 3-year-old with sickle cell? Yeah, concerned about that one. 9-year-old with autism? He's gonna get it. Not the autism, the parvo. 27-year-old woman who recently delivered her first child. Do you hear about that? Nope. 1-year-old with eczema? 10-year-old with appendicitis? 3-year-old with sickle cell? That's a good question. Pull that back. Taking care of a 14-year-old male in clinic with chief complaint of acne. He's tried a few over-the-counter medications, however, nothing has worked. On exam, he has 20 to 30 scattered open and closed comedones, as well as 10 to 20 pustules on his face. Less than 10 lesions on his upper back and chest. What is the most appropriate treatment regimen? So what are you classifying this acne as? Moderate? Yep. So it's more than you're probably going to count. So you're at moderate acne. What are you going to do for moderate acne? Retinoids? And probably, yeah, so you're looking for something that has a combination treatment. Is this the patient that you're going to do Accutane on? No. Is this the patient you're going to do just monotherapy on? No. Right, so you're looking for something in the middle. So all those kind of different regimens, something in the middle here. So BP alone? No. Dermatology for Accutane? No, we just said no. Clinda alone? No. Retinoid plus benzoyl peroxide plus Clinda? Yep. And then retinoid alone. 13-year-old female with a past medical history of moderate persistent asthma presents to clinic requesting an asthma action plan. She has not been seen in your clinic in approximately a year. She says she has no nighttime symptoms, reports a daytime cough and shortness of breath approximately 1 to 2 times a week. How do you classify this asthma? She has moderate persistent. What are her symptoms looking like? She has no nighttime symptoms. So what does that tell you? That it's mild, maybe even intermittent. It's less than 1 or 2 times a week. What are we gonna go with? Is this exercise induced? We have nothing about exercise. Is it severe persistent? She's still moderate persistent? No. And so now we're down into intermittent or mild persistent. How are you going to differentiate between those two? There is a reason this question is not on there anymore. I will just tell you that because the age groups is separated out now. So you have to make it more specific. So this is the old guidelines. Pull this out, right? So it's a little harder with this one. What? Yeah. So this is a bad question because it's with the old guidelines. That's why it's not on there. But this is the exact type of question. Can you pick out which one's mild, persistent, which one's intermittent, moderate? Under the old guidelines, this would have been mild persistent. You are in urgent care. A mother brings in her 9-month-old daughter with concerns for fever and fussiness the past 2 days. She reports that her daughter has 1 ear infection in the past 3 months, and she may think that she has one again. Last treatment for otitis media was 3 weeks ago. PCM's office. She believes she was given amoxicillin at the time. On exam, you see bilateral bulging erythematous TMs with purulent fluid behind the TMs with no evidence of otorrhea. So, do we think that this is a true otitis media? Yeah, I think it's a true otitis media. Was she given the correct medication at the get-go? Yep. When do you give the same medication versus when do you up? Month. So where are we here? 3 weeks. Okay, so what are we going to do? Yep, amoxicillin. What's your dose? 89. Yep. So when would we give low dose amoxicillin? Group A strep. So was that ever an appropriate answer here? Nope. Yes. very common to see bilateral. Most of the time, that's how it's going to present. You have a kid that started with a URI, created that stagnant pond. It started then as an otitis media with effusion, and then turned into full rager. Yeah. Amoxicillin for 10 days at a high dose. Why is that one wrong? Saying that, how would this have been right then, based on this question? Yeah, so if I was said, the last treatment for otitis was 6 weeks ago. Then now amoxicillin drip. Do I refer this patient to ENT?
No.
What would make that correct? 3 to 6 months or 4 in a year. Perfect. I am ceftriaxone. Is that wrong? Yeah. And then augmentin. So this reason I took this question out is because technically it's the next in the next line. There's nothing that says you have to go to augmentin. So technically, ceftriaxone could be a right answer. So I took that out of the real test. Am I giving you the guidelines for asthma? In the lecture. So, yeah. I'm not going to put it up there with the classifications for you. But it's if there's a question like that, I'm not going to do a follow-up. I'll do you a new diagnosis, and it's very, very clear. Father brings in 13-year-old son to clinic, concerns of a facial rash. He has had red, scaly yellow. What already is this? Yep, subderm. Greasy patches on his face, around his ears, chin, and scalp. Some scalp lesions are itchy. The majority are not. Concerned how his skin looks and requests medication to improve the look of his skin. What is the most appropriate medication to prescribe for facial lesions at this time? And? Fluticasol and? What do you mix together?
Oh,
Not Vaseline. Steroid. Low-dose steroid. I think that's why I took this one out, because technically you need a ketoconazole cream for the face. What test should be performed alongside anti-NMICL antibody testing and IgA TTG to perform a workup for celiac? Total IgA. Good. Got it. Which of the following is the most associated with the presentation of infantile eczema? What does that look like on a baby compared to an adult? Face, where else? Not in the diaper, correct? Some cradle cap, you can see those without eczema. Is it on the flexors or extensors? Extensors in a baby, and then on the chest and the tummy too. Yep. Do you see lichenification? In severe, but not diffusely. Extensor surfaces, yes. Skin is less sensitive. Skin is way more sensitive. Persistent to adulthood. Maybe. And then diaper area involved. 18-month-old female presents with increased urination and fussiness. Let's just said that backwards. Which of the following is the appropriate way to obtain a urine sample to evaluate for UTI? Bath. I took this one out because technically you could do a suprapubic cath, and it is valid. So I've never done one, but it is not a wrong answer. So. A 4-year-old male presents to the ER with his parents due to ongoing diarrhea. His symptoms started approximately 3 days ago. He has a fever of 101, intermittent abdominal pain, and 5 to 6 episodes per day of watery diarrhea. He's not been drinking fluids well over the past 24 hours, but is able to drink. On exam, you see a fatigued child who is thirsty. Heart rate, respiratory rate, pulses are all normal. He has decreased tears, and his mouth and tongue appear dry. Urine output is decreased. What is his level of dehydration? It's moderate. Yeah. So this is both. He's got normal vitals, but he also is fatigued, decreased output. So he's in that moderate range. So how do you decide if you do IV or oral? Can you tolerate it? What's it saying that he is? He's not been drinking well over the last 24 hours, but is able to drink. What do you do? You go first. Yep. Admission and IV oral or IV fluid hydration, oral rehydration, oral dansetron and for home use and reassurance, stool tutties plus oral fluid, IV and dansetron and IV fluids. Oral. Yep. Sweet. You guys want round 2 of Jeopardy?
Yes.
Oh, okay. Right. Today's categories that we have. Yikes, that's hot. Is there a shot for that? Eyes, ears, and some other stuff. Breathe in, breathe out. I think it's a rash. Guts and butts. Pick your category. Guts and butts. Oh, shoot. X-ray shows the child is FOS. What does FOS mean? Full stool. What medication is used for a high-dose clean-out? Miralax. What else is that called? PED. What else? How else can I write it out? Polyethylene glycol. Is that different than ethylene glycol? Yes. Male patient comes in with testicular pain, a negative friend sign, and a concerning ultrasound. How long does the urologist have to surgically correct for a positive outcome? 4 to 6 hours. 9-month-old febrile UTI, or 9-month-old male, febrile UTI, renal bladder ultrasound normal. He has a second febrile UTI. Now what? What is it? You already did the ultrasound. What's the next one? B, C, or G. What does that stand for? Yes, voiding cystourethrogram. Cysto goes from the bladder to the urethrogram. What do you do for a workup of celiac? Total IgA. And then what are your antibodies? TTG, which stands for what? Tissue transglutaminase. And what's the other one? Anti-endomysial. Yes. Good. Encopresis. Is it constipation or diarrhea? Thank you. Constipation. Category.
I think it's a rash.
We have the rash. What's the atopic triad? Asthma, atopic dermatitis, and allergic rhinitis. A mom of a child with eczema tells you that the family is colonized with staph. What recurrent treatment will reduce this bacterial burden for the child with atopic dermatitis? You can do the nares. Bleach baths. How much are you going to put bleach in? Quarter cup. Yep. Bleach baths. Your nurse tells you, Mom sent you a picture of diaper dermatitis with satellite lesions. What's your diagnosis? Candida. What do you prescribe? An azole or nystatin. Yep. Correct. True or false? call. So you need to call CPS for flesh-colored, pink, non-tender, dome-shaped papules with central umbilication. What is that diagnosis? Molluscum. What do you do for a child? Reassurance. They go on. Got really into this. Can you tell? What is the treatment option for severe acne vulgaris? What's one of them? Accutane. What if the family's like, I don't want to do Accutane? What's your other option for severe? What does all three mean? Retinoid, BPO, and oral antibiotics. If it's female, then OCPs. Yep. You do. And what if they're like, we really don't want OCPs? What else could you use? Spironolactone. Perfect. Nice. Category.
Breathe in, breathe out.
5 signs, at least, of respiratory distress in a child. Tripoding. Paradoxical breathing. Sure. Retraction. Where do we see retractions? Subcostal. Intercostal. What's it? Supraclavicular. Subxiphoid. Yep. Substernal. You can call it either one. What is this? This is moving. Tracheal tugging. Yep. What about this? Yep. What about the other like super obvious ones? Cyanosis, tachypnea, hypoxia, tripoding, sniffing position, yep. Fatigue. Yep, so you could give any of these. All of those are respiratory distress. What medication reduces subglottic edema for the treatment of croup? Racemic epi. What is the? What else are you giving after you give the racemic epi? Dexamethasone. What's your dose? 0.6. Yep. Is asthma restrictive or obstructive? Obstructive. Squeeze the wheeze. 5-year-old empirically treated for community-acquired pneumonia as an outpatient. He is now getting admitted. What is your antibiotic of choice? 5. Azithromycin and? Which beta lactam? Not third gen sub. Good guess. What would be your outpatient treatment for this kid? Amoxicillin. High dose or low dose? High dose. High dose amoxicillin and azithromycin. So what's your inpatient treatment? Yep. Ampicillin. Yep. Ampicillin is it's IV amoxicillin. Yep. IV ampicillin, IV azithromycin. What electrolyte disturbance can the acute first-line treatment for asthma cause? What's your acute first-line treatment for asthma? Albuterol. What electrolyte does albuterol mess with? Potassium. Does it make it high or low? Low. Yep. The answer to this is a transient hypokalemia. Correct. Your shot. What treatment does WHO recommend for all children with acute measles? Wow. Some stuff, it's so interesting how like it sticks. Like everyone is like vitamin A and like other stuff like ampicillin. What makes it stick?
Well,
What classic infections are concerning for pregnant women in your first trimester versus second trimester? Rubella for the first trimester and fifth or not sixth. What's the other names? Yep.
that one.
I told you I wouldn't put German measles on it, just if the parents does. After an acute case of varicella zoster, where does the virus remain dormant? And what does it cause in reactivation? Causes shingles, what's the other fancy name for it? Zoster. Where does it hide out? Yep, dorsal root ganglia. I missed that on my boards. I put anterior horn cells, that's where West Nile is. I don't know why I told you. Child presents with sandpaper-like rash. What is your treatment dose? First of all, what's your diagnosis? Sandpaper-like rash. Scarlet fever, what does that go with? Group A strep, so what's your treatment?
Low dose.
Low dose strep, what's that? 50. Yep. See, you guys are getting it. It's totally great. This is backwards and forwards. You guys are awesome. What 2 infectious diagnoses can you treat with permethrin? Scabies. What is the name of scabies? Yep, and then what is lice called? Good. Okay, when tired, the left eye deviates to the nasal bridge. What is that called? Esophoria. Yep. Left esophoria. What is the underlying cause of a hordeolum? What's the other name for hordeolum? Staph. What causes that? Staph. Where? In the meibomian glands or lice? Yep. Nice job. True or false? A workup for orbital cellulitis includes a CT scan. True. That was too easy. I need to change that. Child, bilateral otitis media 3 weeks ago. Repeat exam worsening. Child is febrile. Man, I use that one too much. What's the next one? Augmentin. Yep. And then what's the next one after that? Rocephin. What if in the course of that they have anaphylaxis? Azithro. 14-year-old male comes in for allergic rhinitis, says he uses a nasal spray that he got during a URI that worked like magic for the last 6 months. What secondary diagnosis is likely? Rhinitis medicamentosa. What's it probably from chronic use of? What's the other name for after? Last but not least, what is your appropriate age and dose for Tylenol? 2 months and older? 10 to 15 mg per kg. How many hours? 4 to 6 hours. So no fewer than 4. Guess what the next question is going to be then? Ibuprofen. Yep. What's that? 6 months. 10 mg per kg. 6 to 8. Yep. Perfect. Yeah, it's technically 5 to 10. Nobody's ever used 5 in the history of ever. Fever lasting 6 days with no etiology is termed what? Fever without a source or fever without a focus. Name 2 meningitis causing pathogens that vaccinations are available for. Wait, what? PED Not measles. No. Strep pneumo? Yep. What's your other one? Neisseria. Yep. So that's 3. Yep. Strep pneumo, Neisseria, and Haemophilus influenza. Okay, you know the first line treatment for meningitis is blank and blank. What's blank and blank? Bank and ceftriaxone. But the patient has a beta-lactam allergy. So what are you going to use instead? Oh, that's too easy. That's way too easy. Oh, it's actually a good Okay. How do you do it? They're not. They're severely dehydrated. Severe. IV. What does that mean though? Okay. So what fluids are you using? Normal saline. What's your dose? 20 milliliters per kilogram. How long do you give it over? 20 minutes. And how many can you give before you have to admit?
3.
What do you do in between each bolus? Reassess. Yep. Normal saline or LR, for our purposes, use normal saline, 20 mg up to 3 times over 20 minutes. And is there clinical improvement? Questions, comments, concerns, anxieties, frustrations? Is this helpful? Do you feel like we're ready? Or you know what to say? Yes, sir. If by 3, so if you did bolus 1, you reassessed, you still look dehydrated, you haven't peed, you have no tears, your heart rate's still high. Bolus 2, reassess, no bueno. Bolus 3, still throwing up, still look like that, now you're good. Good question. You guys good? Text me, call me, email me, send a pigeon.